a lure lock that just go on the front, and then your tubing does the exact same. Now this is more important because on the tubing, one's labeled with a number 1, the other one has number 2, and you can see here it says overtube and endoscope. You don't want to get those back mixed up. So this tubing, the longer one, is going to go to the overtube, and then the endoscope one obviously goes right here. And then what we'll do is the endoscope gets plugged right here onto the scope. So that's going to blow up and deflate the balloon on the tip. And then this one here is going to blow up and inflate and deflate the balloon on the overtube. And what you'll do is put this tubing on the clear. Turn this on. And you can see now it's turned on. This is overtube, endoscope. With it smashed like that, and that means it's deflated, and you can see both balloons are sucked completely flat. So what we'll do is inflate, and now you can see both are blowing up. I usually let them get blown up about that big, and then just hit the pause button for me, both of them. Okay, and that's holding the air pressure. What you want to do is just look down here to make sure that these numbers aren't drastically falling off. If they're falling, then you have a hole in one of the balloons, and then you got to get a new balloon and everything, or a new overtube. Okay. Since we don't have any kind of hole and they're holding pressure, then all we'll do is just deflate them, and now it's going to take the air out of those. Okay. And then that will just sit there, and now we're ready to start the procedure. Okay. So then during the procedure, this is what you'll hear. The physician will say either overtube or endoscope, up or down, and that's what he's just saying is I want that up, that one's down, vice versa during the case. And what we're doing is, like I said, we're going to go down as far as we can with the scope before we start using anything. And then what he'll do is, once we get as far as we can, or as far as he wants to push in the patient, then what he'll do with the scope, well, making a mess here. Oh boy. There we go. Perfect. So once he gets as far as he wants in the patient, then he's going to say, okay, let's slide the overtube in. So he's going to push the overtube down into the patient. And we're going to watch the tech, or whoever's pushing the overtube is going to watch to make sure that we don't go past this white line at 155. Because if we do, then we know we might end up pushing this balloon off the scope. Okay? And so that's our marker. So once you get to 155, you tell the doctor, and then he's going to say, inflate your overtube. So he's going to inflate the overtube, and that's going to hold our position in the bowel. And then what he'll do is have you hold this kind of out straight, and what he'll do is get the scope, and he's going to push it, as you can see, he'll just push it farther down into the bowel, into the small bowel. And then once he gets up here to about the boot, he'll say, okay, let's inflate the scope. So he'll inflate the scope. Usually wait about 3 or 4 seconds for that to get inflated. Once that's inflated and it stops beeping, then what he's going to say is deflate the overtube. So that's when tech will deflate the overtube, and then we'll slide this back into the patient until that white line, okay? And then he'll say, okay, now we need to inflate. You'll inflate this, and then what we'll do is we'll have, let me get this inflated and I'll show you. Okay, so then what he's going to do is he's going to have both balloons inflated at this point. What the doctor will do then is he'll grab the scope and the overtube, and he's going to pull this back kind of out of the patient, and that's where he's pleating the bowel over the scope. Okay, so he's kind of pleating the bowel, what he's already seen, and then once he feels that get tight, he'll say, okay, it's tight. He'll say deflate scope, and then he'll deflate the scope, and then he'll push this farther down the bow, and kind of do that same sequence all the way through. Okay. If you're ever running the controller and he says like something wrong, or you look down there and you're going to have both balloons deflated, just say stop. Hey, if I do that, I'm going to have both deflated, and then everything's going to kind of go flying past you. So it's a teamwork thing, and you can, I tell people, you can yell at the doctor, because a lot of times they get going and they kind of forget what balloon they've got up or what they have down or not, and you just always want to have at least one balloon inflated, because if not, everything that you've already seen is kind of going to go flying past you. Okay. And then if they ever see anything that they want to take care of, or you see something on the way in, go ahead and tell them, because most of the time you want to take care of an AVM or a polyp or anything like that on the way in, because you'll see it better. Because when you come out, a lot of times the bowel kind of is jumping and you'll miss stuff. And so you always want to take care of it on the way in. Okay. And most of the time what they'll do is they'll leave this overtube balloon inflated if they're going to take care of something, so they can still maneuver the scope in and out to find, to get that polyp or get an AVM. Okay. And then once they're done, or as far as they've gone, the sequence is just opposite coming out, because they're still going to want to, kind of go slow through the bowel and see everything. Like I said, a lot of the folds and stuff are going to jump, but they'll do this same sequence of inflate, deflate, just different, backwards basically. Okay. A couple times I've been in cases where the doctor says just deflate both. There's maybe a problem with the patient, and then he'll just pull out. That's totally fine. But if you ever run in the controller and they say something and you're like, oh, wait a minute, let's make sure we're on the same page, just so you don't lose all that stuff. Most of these are taking, Rachel, they taking an hour and a half, maybe. Can be 2 hours depending what they're looking for. Sometimes they might go rectal. If the capsule that they've seen something on is really far down the capsule, they might do it rectally instead of through the mouth. But most of the time it's through the mouth, and they're looking mainly for AVMs or a polyp or some sort of bleed area that they've seen or anything like that. So,
should you need to do anything with the water port during the case?
Yeah, if you are running the overtube or the doctor complains that this is not going through very smoothly, what you can do is just add water to the blue port. And obviously it's just that there's not enough water in between the overtube and the scope, and he might notice it's not sliding very well, so you just add a little more. I usually add about 10 cc's of water through that port during the case. But
normal water?
Just normal, yeah. Sterile water's fine. Yeah, and you'll notice, like if you're running the overtube in and out of the patient and it starts getting a little tough, you might say, hey, I need to get some water, or he might say that when he's trying to push the scope in. And most of the time when we set this up, we kind of get everything behind you in the room, so you have as much room, because a lot of times when hold this for me, when he's coming out, he's going to be maybe even standing this far from the patient. Like, you're the patient, because he's pulling the scope out slowly, and so it's he doesn't want it hitting the floor and things like that. So he might have a lot of this equipment kind of behind him, and he's moving backwards. Just so you know that when we're in the case. They had a problem the other day. I guess we can go over some troubleshooting. They had a problem the other day where the balloon on the scope was not inflating properly. This balloon here. What happened was, during the setup, they didn't flush this port with air enough, and there was a lot of water still in the scope, so it wasn't inflating or deflating properly. So that's where I was saying you want to run at least 6, 7, 8 of those syringes of air through that port to get all that water out.
10, 15, 20.
10, 15, 20. Maybe just put oxygen tubing on it. Either way, just to get all that water out. Okay. And like I said, if you ever notice any water in either one of the tubings, get another set and make sure you dry it out, because it can hinder the inflation and deflation if there's water in that tubing. I even had one account where they got water back into the filter, and it kind of shut the whole thing down, so that it wasn't actually inflating or deflating at all.
So do these only inflate the maximum of the pressure on the bowel?
Exactly.
Okay.
Exactly. Yeah. And you might hear an alarm once in a while. Let me see if I can make it do it. So you might hear an alarm when you're in the case. Let's see if it'll go off.
FFF.
Yeah. So it's feeling a lot of pressure. And it's not going to do it today. but it will alarm, and it's basically when there's your alarm, and that's just feeling too much pressure on the balloon, and most of the time that's when he's doing what we call the reduction, where he's pleating the valve and he gets it a little tight. So all you'll do is just hit the stop button, and that will shut it off, and then the pump will reset and stop itself. But most of the time the pump will, you might hear it do that once in a while, and it's just really the balloon feeling the bow. And if it's in between a fold, you might hear the alarm go off, but most of the time it'll shut itself off. Yeah. And like I said, any of your devices that you use for your colon will work through the scope. It's got a 3.2 channel in it, so your clips, your forceps, your snares, your injection needles, any of that stuff will work, your Irby probes, all that. But most of the time what they're looking for is some sort of bleed, whether it's an AVM or a polyp or something that's bleeding, and they've seen that on a capsule, and then they're going to go in and take care of it. Okay?